decades, health policy has been dominated by economic thinking and by market-based solutions to the system's biggest problems, including low-value health spending. With market-based policies leading the way, the goal of law and the goal of regulation become to define and lubricate markets, to get the markets to work, and to help people make good choices in them. So the promise of market-based solutions, if you kind of go back to the initial discussions around it and the nascency as compared to direct regulation, was that market-based solutions would be more responsive to individual preferences, and they would be less bureaucratic. But in the healthcare space, market approaches are predictably not producing either of these results. None of the conditions for well-functioning markets exist in healthcare, as Ken Arrow warned 5 decades ago. Plus, a wealth of research since then has illuminated why people are not good consumers in this space. People don't have stable preferences about things like health insurance plans and medical care in many instances, and when they do, they can't translate them well into decisions. We've seen a ton of research showing that health literacy is low, that numeracy among the population is low, and health insurance and medical care decisions are notoriously complex, technical, and hard. So in response to struggling markets and struggling consumers, we've created a massive regulatory scaffolding to try to bolster market-based policies, often with little success. And then when we create these, as we're trying to get the markets to work, it demands constant technocratic tinkering to make them better and better, that we as academics, that the media, and that regulators spend a lot of their time and attention on. So take the example we've talked about today a little bit already, the ACA exchanges. They're very loosely built on Alan and Tobin's idea of managed competition. People will choose wisely among health plans in a managed market, and their decisions will prompt insurers to offer higher value health plans, in turn improving healthcare delivery to do so. So the exchanges, while they have created some good results, undoubtedly, they have fallen well short of this promise of good decision making among robust plan choices. The response has been to double down in an attempt to fix them. So preserve competition, which is usually defined as getting enough insurers into the markets, and help people choose better, despite mounting evidence that the latter efforts aren't working particularly well. And one of the studies I cite in this section is a simulated study by Eric Johnson and others, including my colleague Tom Baker, who is a senior fellow of LDI, and it's called Can Consumers Make Affordable Care Affordable? The Value of Choice Architecture. And it showed that people have even odds of picking the most cost-effective health policy among 4 options. They do even worse with 8 options, and Wharton MBAs get it right only 75% of the time. So the study tested whether things like incentives and calculators and defaults with an opt-out would help. The only intervention that significantly moved the needle was the default. Studies on the ACA exchanges, Part D, Medicare Advantage, all showed similar decision-making errors. So even though much of this evidence was available before the ACA exchanges rolled out, we've spent billions of dollars now to establish and bolster exchanges, expecting people to make good decisions. So if what we have to do to get people to choose the best plan or the right medical plan is to default them into the best option, we have to ask if choice is really doing work, if it's really getting us anywhere we want to get, or whether we're building a massive market-based bureaucracy to hold up these markets with little payoff. So what I won't have time for today is to lift back and say, well, why have we gone down this path that was doomed to fail and where we go next? But that's the goal of this project, is to think a little bit about why do we continue going in this direction despite mounting evidence that it's not working, and how do we start to shift the conversation?